check they haven't got any electronic devices or smartwatches or anything like that in the room, whether they're switched off or not. Thank you very much.
Yes, Ms. Pottle.
Yes. Sir, before you, you have Dr. Stephen Jukes. Please, may the witness be sworn.
Please.
Right hand. Repeat after me. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you.
Thank you.
Thank you, Dr. Jukes. Please sit down. The questions will come from over there. The microphones are what to aim at. They're mostly recording rather than amplification, so speak clearly.
Thank you.
Hello.
Hello.
My name is Emily Pottle, and I'm asking questions on behalf of the inquiry. What is your full name?
My name is Stephen John Jukes.
And Dr. Jukes, on the 29th of June of 2018, you were the on-call intensive care unit consultant at Salisbury District Hospital. And you were on call and caring for Dawn Sturgess from her arrival on the 30th of June until Monday, the 2nd of July of 2018. Is that right?
That's correct.
You were also responsible for the care of Charlie Rowley from his admission on the 30th of June until Monday, the 2nd of July. Is that right?
That is correct. I did also look after Charlie Rowley a bit later on in his admission, towards the end of his admission.
I see. And you did have a role in the care of the Skripals, is that right?
Yes.
You were part of a team of, at the time, 5 or 6 intensivists
Yes.
at Salisbury District Hospital, and you, together with your colleagues, you remained in the loop, so to speak, on their care and occasionally attended clinical advisory group meetings. Is that right?
Yes, we were very... the information that was ongoing within their care and direction of care was given to all of us who were there as intensive care consultants, and we shared that amongst each other at all times. So we all had a very good working knowledge of what was going on.
Yes, thank you. There's also a statement from your colleague who cared for Charlie Rowley and Don Sturgess in the intensive care unit. And those statements are from Dr. Martin Cook. The references, we're not going to pull them up now, but sir, for your note, are INQ 004407, INQ 004553, and INQ 004554.
All Cook.
Yes, that's
Yep.
right. And if I can ask, sir, if they can formally be adduced into evidence.
Yes.
Dr. Jukes, before I ask you about your role in the care of Don Sturgess and Charlie Rowley, I'd like to ask you about your awareness of the risk of a discarded container of Novichok. Following the attack on the Skripals in March, the authorities recognized the risk that Novichok may have been discarded, posing an ongoing risk to public safety. And I'd like to pull up now document INQ 004704. If we can scroll to the next page, please. Yes. Dr. Juice, this is a document not prepared by anyone at the hospital or any of your colleagues, but it is a document created by an official at the Department for Health and Social Care, and it posits a reasonable worst-case scenario. We can see that's the second title down. And it's considering, oh, if we could just stay, pardon me, at the top just for a moment, thank you. It's considering a reasonable worst-case scenario in the event of three different but related incidents. So the first is that there would be a second targeted attack on specific individuals.
Have you seen this before, Dr. Jukes?
I've not seen this before. I think I was aware of it from reading the transcripts from last week. I think it might have been mentioned, but I was not aware of it before then.
Okay, thank you.
The second reasonable worst-case scenario is accidental discovery of a discarded agent by humans. And the third is accidental discovery of discarded agent via animal indicators. And we can see here that the second worst-case scenario is the one that eventually did happen. So accidental discovery of a discarded agent by humans. And then if we now scroll down to the next page. Oh, pardon me, if we just pause there, sorry. In a bit more detail about the scenario, up to 6 members of the public are exposed to source material used, including up to 3 children. The material is found in a public but not a crowded area. Up to 4 emergency service personnel are exposed, and there's 1 fatality, 9 other casualties requiring prolonged hospital treatment. Contamination is restricted to a relatively limited area around the discarded source, and a further 50 people are potentially exposed to secondary contamination. So the scenario, not a million miles away from what did actually happen. We had 1 fatality, of course, when Don Sturgess uncovered the material at 9 Muggleton Road. If we can then move on to the next page, please. And here we have a discussion of the consequence management in each sort of scenario. And one of the questions posed is, in terms of hospitals' infrastructure, what hospital capacity is available, what knowledge or training do hospital staff or other healthcare professionals have, what PPE is available for clinical staff treating the casualties, and so on. So, Mr. Jukes, we can see that some quite detailed consideration was being given by officials, certainly at the Department for Health and Social Care, to a scenario which, in fact, quite similar to the one which did occur, this discovery of a discarded container of Novichok. But these detailed considerations of that risk, they were not shared with you, is that right?
No, they weren't.
If we can move on to document INQ 004178 at page 28, please. This is a record of a public interview being given by one of your colleagues, Dr. James Haslam. And he says, on discharging our last patient, there was a real sense of relief or accomplishment. Things started to return to normal. All the fanfare of the press and everything had gone. In the back of our minds, there was a sense that the police haven't found the Novichok, and so there was a real niggling feeling. Could it still be out there? Do we need to be worried? And what I'd like to ask you is, you weren't shown the quite detailed risk assessments being carried out, but Dr. Haslam's evidence was that he was worried at the back of his mind in any event. Did you have those worries at the back of your mind that there could be a discarded container of Novichok?
I think that every one of the intensive care unit consultants at Salisbury Hospital who was involved with the Skripals during their admission shared the same worry.
Okay.
Including myself, obviously.
Okay. So you and the other, certainly the other intensivists
Yep.
at Salisbury District Hospital, you were worried at the back of your mind following the Skripal attack that there could be some Novichok out there, is that right?
Yes is the answer. Obviously, months had passed since the initial Skripal incident, and a third of the year had passed effectively by the time Dawn was admitted. That concern doesn't go away, but as more and more time continues, you start to have you would have to have some faith in the fact that the amount of almost industrial movement that went on around Salisbury in materials, bricks, benches that were taken away, houses that were taken away from families such as Sergeant Bailey and his family. All these things fed into that narrative that maybe they had cleaned the area. 4 months had passed. You'd think that most bins, it was hard to see how bins and the like hadn't been emptied in that time. But it was still possible. It was clearly possible that Novichok would be found at some point. But time hadn't shown it up to that point.
Okay. So would it be fair to say that it was still perhaps at the back of your mind,
Yes.
but as time moved on, you perhaps gained a confidence that if there had been anything else out there, it would have been found?
Yes, but it wasn't that it was removed at all. Initially, we had expected a higher number of casualties coming into hospital at the time, and that didn't happen to the level that we were worried about. And then weeks, then months passed, and it still hadn't happened. That worry had never gone away, but you were hoping that you were beginning to find, I guess, business as normal with our patients that were coming to us.
I'm going to ask you now about Dawn Sturgess's admission to the ICU and her care on the 30th of June. I'm going to take you to your statement, which is inquiry reference 4411, page 2, paragraph 9. You record in your statement, the history given to us by the ambulance crew was that on the 30th of June of 2018, Miss Sturgess had felt unwell with a headache. She had taken some medications and then had an unwitnessed collapse in the toilet. A 999 call had been made at 10:14, and by 10:25, the ambulance crew were on the scene and found her in a state of cardiac arrest. Resuscitation attempts began, and treatment for cardiac arrest was given. There was a return of spontaneous circulation, a ROSC, noted at 10:50, and ROSC is where the heart begins beating in a coordinated fashion, but this does not always mean that blood flow or pressure will be adequate. There can remain a requirement to help the heart and blood pressure stay within normal physiological parameters by using specific and standard treatments. Dawn Sturgess, when she arrived at in the ITU, she was already intubated and she was ventilated. Is that right?
Yes, that's correct.
Okay. And you describe in your statement that she had an accumulation of acids, which can make it difficult for her organs, including her heart, to work properly. Is that right?
Yes.
Yes, okay. And in your statement at paragraph 15, you talk about a differential diagnosis.
Yes.
So different options for what could be the cause of Dawn's symptoms. So the first option is a headache. Her headache raised a suspicion of sudden specific intracranial bleed called a subarachnoid hemorrhage. So if we could just scroll down to paragraph 15, please. There, so thank you very much. We see paragraph 15A, so the first option, the headache, had raised the suspicion of a sudden specific intracranial bleed, which could be associated with a sudden cardiac arrest. And a CT brain scan would be needed to exclude that differential diagnosis. And in the event, and we'll come on to the medical records in a moment, the CT scan was performed at that early stage and ruled out the possibility of a subarachnoid hemorrhage.
Yes.
At that stage.
Sometime that day, at any rate, is that right?
No, it was done. So just after Dr. Dawn Sturgess had arrived in our emergency department,
Right.
she was taken from there to the CT scanner.
Good, thank you. So that excluded the subarachnoid hemorrhage, did it?
Well, near enough. You can sometimes get small ones that aren't picked up on the first scan, but for what we were looking for, then yes. There are certainly other intracranial pathologies that were possible that may not have, just don't always get shown up on the first scan, and can give very small pupils, for example. But the first scan was reported as showing nothing acute.
Thank you.
The second possibility for the differential diagnosis is at paragraph 15B. So you describe that as a prime cardiac reason. So a structural problem of the heart or heart arteries, or a sudden altered rhythm that became uncoordinated and ineffective, leading to her heart stopping. And then you note also that when she arrived, her potassium levels, because they follow acid levels, and the acid levels were quite high, you would have expected them to be, that her real level would have been quite low.
Yes.
And that a low potassium level can cause alterations in heart rates, and that can degrade to a rhythm which would cause a cardiac arrest. Is
Yes.
that right? So we have on the one hand the subarachnoid hemorrhage, and then the prime cardiac reason. And the third option which you considered is at paragraph 15C, the medications history, which you'd been told about by the paramedics. So she had taken some medication before she collapsed. That raised the possibility of a sudden anaphylactic reaction to her medication. So we can see here in your statement, the medication's history raised the concern of a sudden anaphylactic reaction or the possibility that the medications taken might have caused respiratory depression, such as happens with opiates. One would normally expect more physical clinical signs, such as a rash or a wheeze, to support a differential diagnosis of anaphylaxis. Although it is important to note that sudden cardiac collapse can be the only sign of anaphylaxis. So you say we couldn't rule that out. The timing of the medications taken by her did not support opiate use, although it was possible that opiates or other medicines had been taken already a little time before, as Miss Sturgess had pinpoint pupils. Can I just ask you to clarify something? So you say that the timing of the medications didn't support opiate use. What do you mean by that?
In the sense that it sounded like she had taken some medications and almost immediately afterwards had a collapse and was unconscious, and then her breathing and her heart had stopped. To absorb opiates in that time frame, I can only imagine there would have to be exceptionally strong opiates, because you're talking probably seconds, or if they were being given intravenously. It was therefore possible that maybe the pinpoint pupils were related to that. It was possible, but more likely that if opiates had been party to this, that they were taken a shorter time beforehand.
I see. So it was too quick, if we can put it that way, for those medications to be taken in, and for suddenly, if it was an opiate.
I think orally, then that would have been too quick.
I see.
If I just may add, the differential diagnosis is not meant to be, these are the only things that we think of. They're meant to be, what do we have in front of us at the moment when somebody arrives into hospital? What immediate options that we can investigate to try and rule in or rule out, given the information that we have up to that point. The differential diagnosis is there to be adapted and either supported if you have investigations that come back positive, or allows you to develop further as more information comes to light.
At paragraph 16 of your statement, you say that there was nothing about the history provided by the ambulance crew, and perhaps we should bring this up. Paragraph 16 of the statement, which is page 4. It's a little difficult to read. But you say there was nothing about the history provided by the ambulance crew or by Miss Sturgess's clinical presentation when she arrived to alert you to the possibility of a second Novichok poisoning. Is that right?
Yes.
If we can now turn to the contemporaneous medical records. They are inquiry reference 000130. If we begin on page 2. We see the first entry on the 30th of June, there on the left-hand side, and it says M, I think that's Mortar, is that right?
It's Mortier.
Mortier, I see. And is that a he or she?
It's a she.
It's a she.
She was the registrar on during that day.
Yes, I was going to ask you, SPR, does that mean specialist registrar?
Yes.
So she's the registrar in charge of anesthetics in the ITU, is that right?
That's correct.
Okay. So she records the first notes here. She says, pre-alert to emergency department recess at 11:57, attended immediately. 44-year-old woman, limited HX, that's history, is that right?
Yes.
Okay. Post ROSC, so she's had that resumption of spontaneous circulation. And she records the background here that she felt unwell with a headache. She took meds, query what those actually were. She had an unwitnessed collapse in the toilet. The crew arrived at 10:25. PEA arrest confirmed. So that's pulseless electrical activity. Is that right?
That's correct.
Okay. 3 times adrenaline and CPR given. And then they describe the ROSC. She describes the ROSC at 10:50. So downtime about 30 to 40 minutes, which is quite a lengthy period. We'll come on to that later on in your evidence. Then she describes some of the medications given, including adrenaline, midazolam, and that Dawn was still bradycardic. So with a heart rate of 30 to 35 beats per minute, that's quite slow. Is that right?
Yes, that is slow.
And she's described as hypotensive, so she has a low blood pressure. Is that right?
Yes.
Okay. And in the left-hand side, we have here PMH. What does that stand for?
Past medical history that they would have been aware of at the time.
Okay. And we have 3 things recorded here. Can you help us? What does the first one?
Alcohol excess.
I see. How? Because it
Ethanol.
looks as though it's an ETON,
ETOH.
but that must not be right.
ETOH,
ETOH, okay. What does that stand for exactly?
effectively ethanol.
Ah, I see. Okay. So ETOH-X means a history of alcohol dependence. Is that
Yes.
right? Okay. And underneath that, something that looks like a pitchfork, what does that mean?
That would be or allude to potential psychiatric history. I guess it's just a symbol, a psi,
I see.
Greek letter.
And then underneath that, we have fall, February 2016, admission for fixation, severe electrolyte disturbance, and I think that says PIC line, is that right?
Yes.
So she had a fall and she was admitted to hospital to help fixation, is that?
If I remember rightly from going through her notes later, I actually thought it was February of 2018.
I see.
She fell and injured her arm. And at that time, it was also noted that she had low levels of potassium.
I see. And Dr. Mortier then records that on arrival, IV, and then she records, I think, are those drugs being given to her?
What you have there is IV intubated and ventilated.
I see.
She describes that the endotracheal tube, the tube that has been placed into her trachea to ventilate by, was of a size 6.0. That describes its diameter, and at 21 centimetres would have meant that the length of it was 21 centimetres, usually at her teeth, but it could have been at her lips, but I would imagine it was at her teeth.
Okay.
In the mentions of, sorry, did you want me to go on?
Please.
She has a tick next to what is end-tidal CO2 to describe that the monitoring machine that she was on was registering that ventilation was happening, that the tube was not placed in the wrong position, such as into the esophagus. She felt there was bilateral air entry in both lungs. There was some secretions, and that was Dawn, was making good respiratory effort. So despite having what was presumed to be ultimately a respiratory then cardiac arrest, with no additional treatment, she was now having breathing effort. And that breathing effort wasn't quick, 10 to 12 breaths a minute. The RR is respiratory rate, but it wasn't slow. Mm-hmm. And her saturations were acceptable, although she was getting a good flow of oxygen, which is what the 15 litres of O2 of oxygen mean. And then there's an image, which is an image of her lungs and a comment of bilateral air entry.
I see. And if we continue on to the next page, we can see further information recorded, including that her blood glucose is 8, her pupils are 2 and 2. Would that indicate meiosis at that stage?
Yes, I mean, it's small. They could be smaller, but it would give the impression that the pupils appeared constricted.
Okay. And there's recorded diarrhea ++, And then temperature. I mean, I suppose it doesn't tell us at that stage whether the temperature is high or low.
No, but certainly the temperature that's been recorded that I remember from either in ED or that when she first admitted to the ICU was round about 34 degrees.
So low.
It was low. Would probably be in keeping with what I would have expected for someone who's had an out-of-hospital cardiac arrest and to some degree was exposed at the time.
Yes. We can also see that she was given atropine, 500 micrograms, and that would have been to increase her heart rate.
Yes.
Is that right? So it increased her heart rate to 115. And of course, we know now that the atropine would have also had some helpful effects on the organophosphate poisoning, in fact.
It would,
That wasn't known at the time.
no, it wasn't known at the time. It would have had effect on the muscarinic symptoms of that poisoning, but not of the function of the enzyme.
Yes. We can see a little further down the page, TX to CT, so that's taken to
Transfer to CT.
CT, okay. And then underneath, we can see CT verbally NAD. So that means, tell us, what does NAD mean?
People interpret NAD differently, but no actual defect would be, or no actual defect would be the summary of that.
Okay. So we can see here that at a very early stage, in fact, it says at 12:46, she'd been transferred for a CT scan of her brain.
Overhead, yes.
Yes, and that had shown that there was no subarachnoid hemorrhage. So
Yes.
that you could sort of rule that out as one of the possibilities.
There are some subtle things that don't necessarily show up straight away in a CT scan, but it was at that moment, in many ways, it would have been a base level scan. Had we seen further damage on that scan, that would be quite a damning sign. It's not uncommon that the first CT scan is effectively unremarkable if it's ruled out other reasons why you were doing it, and in this case, to exclude out a subarachnoid hemorrhage.
Yeah. At the bottom of the page, I think there's your first entry on the records. So we see, I think that's Jukes 1740. Do you see that?
Yes, I do.
It says continues to have, I think, periods of bradycardia at 45, so 45 beats of the heart per minute. Is that right?
Yes.
Yeah. She continues to be dependent on oxygen, I
Yes.
think. And if we turn over the page, we can see that she still has hypothermia. You've introduced a nasogastric tube to help with her nutrition, and you note the risk of refeeding syndrome. You think she's at risk of that, so it's a slow process to introduce those calories.
It's always important to give feeding to people.
Yes.
Calories are energy. There are groups of people where you would, as you say, introduce that feeding more gently because it can have, otherwise it can have quite dramatic effects on the person's electrolytes, and they can then go and cause further problems, particularly with the heart.
You also note here cardiac arrest support, so support that's being given to her heart.
Not necessarily. After someone's had a cardiac arrest, it is obviously about trying to support the cardiac system, but that is to try and support the brain from having any further injury. What's happened already to the brain has happened, and you're trying to prevent secondary injury from happening. So they describe it as a bundle of physiological care that you would give to somebody to try and minimise this sort of secondary injury. That includes, for example, not trying to warm them up. It is actually quite helpful that they are cool and they warm up perhaps in their own time. Some people actually actively try and cool people. The evidence certainly is that you don't want them warm. You don't want them over normal temperature or hyperpyrexia, which is the word that I've used.
Okay. So it can be beneficial for them to have a low temperature. Certainly you wouldn't want to artificially increase it.
No.
Okay. We can see underneath your entry is another one from Dr. Mortier. She describes the outstanding jobs, urine tox screen, to chase the screens for paracetamol and salicylic acid. And then at the very bottom, she says, Dr. Jukes, ongoing bradycardia, large amount of saliva on admission, pinpoint pupils, diarrhea, most likely not to be of significance, but noted. Did you observe that, that she had a large amount of saliva on admission?
No.
So Dr. Mortier here is presumably describing her own observations, and we know that she's the one who actually attended.
So she had attended Dawn as she was admitted into the ED. This was not the first time that I'd seen Dawn. I would have had contact with Dr. Mortier in the ED. It's not unusual to have some secretions in people who have had a breathing tube put in. They're not always from the mouth. They could sometimes be contents from the stomach that are regurgitated up into the mouth. Certainly, it's not in its own right something that would flag worry. But and the diarrhea, we
Can I just pause you there before we discuss
Do
the
apologise.
other problems? The large amount of saliva on admission, so did you know about it from reading Dr. Mortier's note at the time, or were you simply not aware of it?
I would have thought she would have told me these things. I can't remember that, but she certainly did mention it as she has documented. I remember that, the conversation about it. There wasn't a great deal of saliva when I replaced her breathing tube, which is alluded to at the top of that page, but she had had some glycopyrronium in that time, which could have absorbed those secretions, but if anything, I thought it was actually quite dry. So I was aware of that. And I took on board what she was passing on, but I had other possible explanations for some of those things, and so wanted to, I guess, store it as opposed to think that this was definitely something else going on.
Okay.
Just a minute. This might be, but I don't know whether it is, Dr. Mortier's note of a conversation with you.
Yes, she spoke to me.
Does that accord with your recollection or not?
At that time, she spoke to me.
Right. So whoever you've been asked questions about, for example, saliva, whoever had spotted it, Dr. Mortier and you had discussed it. Is that right?
To me, this is her making a note of the fact that she had spoken to me at that time, explaining that when Dawn came in, there was lots of secretions.
Quite.
And I was absorbing that information and not ignoring it, certainly accepting that I hadn't found anything myself to support it at that time, but was keeping vigilant about it.
Yeah. And are you accurately recorded or not, as having said probably not, most likely not of significance?
If you absorb that sentence, that it was taken and not ignored.
Yes. All right. Thank you.
I'm not suggesting, Dr. Jukes, that you should have reached a diagnosis of organophosphate poisoning at that
No.
early stage, but Dawn was displaying many of the symptoms of such a poisoning, and I'll just take you through them. So we have meiosis, the secretions, diarrhea, respiratory and cardiac arrest, bradycardia, and hypothermia. Would you agree that those were symptoms of organophosphate poisoning?
I think the symptoms you've described, if you take out of context of how Dawn presented, are symptoms of organophosphate poisoning, or certainly inhibition of the acetylcholinesterase. I don't feel that they were, they can be commented on in hindsight looking for these things, that almost a degree of confirmational bias, that you're looking for things to support what you've already know to be true.
Yes, if I could I'm just going
Yep.
to pause you there to say that the experts who we'll hear from later this week, they have said, and we don't need to pull it up, sir, but for your note, it's inquiry reference 5994, page 116. And this is at paragraph 27. They say, at the time of admission, although Dawn Sturgess showed several features consistent with organophosphate poisoning, most of these could reasonably be ascribed to the post-cardiac arrest state, particularly in the context of a possible opioid overdose. In our opinion, it was reasonable not to have treated or tested her for organophosphate poisoning. So would you agree there with the experts saying that those symptoms could be ascribed to the post-cardiac arrest state?
Yes.
There's one other symptom I'd like to ask you about. One symptom which is not recorded in the notes at this stage, but was recorded by the paramedics, was sweating. So paramedics had noted that Dawn Sturgess was sweating so much that the plaster holding her cannula in place had to be refixed when she was in the ambulance. And we don't need to pull it up, but the inquiry reference for that is 5142. Is it possible, do you think, that the atropine, which was given to Dawn to increase her heart rate, do you think that might have stopped that sweating when she was admitted at that early stage?
Atropine is going to affect acetylcholine. Acetylcholine can cause you to sweat. So yes, it has to be possible. I was not aware of her sweating story, and at the time of arrival she wasn't sweating. Certainly, a cardiac arrest can drive that moment of intense sympathetic discharge. I know you had that discussion about sympathetic and parasympathetic systems. Acetylcholine is part of that sweating element of the sympathetic system, and if your body is at a life-threatening point, it's possible that could be the driver of the sweating. But we didn't know about the sweating, and when she first arrived, it wasn't commented on as being a problem.
No. We'll go through the records for later on during her stay, and there is a mention of sweating at a later stage, but at this stage, there wasn't a record of sweating. And you're saying that it's not something you observed yourself? Okay.
That's right.
Okay. I'd like now to turn to Charlie Rowley's admission to the ITU. So if we return to your statement, which is inquiry reference 004411, page 6, paragraph 28. And I believe, Dr. Jukes, there's a correction that you want to make to paragraph 28. Is that right?
Yes.
So it says here during the day, and can you just tell us how you would like that first sentence to read?
During the late evening.
Okay. So during the late evening, the partner of Miss Sturgess had also been brought into the hospital with a similar presentation. He was known to have a drug dependence history, and his presenting symptoms could have been accounted for by opiate excess. It was unusual to have two patients present in such similar ways, but clearly possible in the context of drug excess. We were also aware that the ambulance crew, which delivered Miss Sturgess's partner to Salisbury District Hospital, had concerns that a possible chemical injury, such as Novichok, was causing his symptoms. I do not know why this was considered, but it led to concerns that clothing and medical kit may need to be taken for decontamination on arrival at the hospital. The ED consultant at the time contacted one of his colleagues, Dr. Russell, who has experience in this area. his opinion was that it was highly unlikely that a chemical weapon was involved and advised that decontamination measures were unnecessary. The first thing I'd like to ask you about in regards to that paragraph is the reasons behind the paramedics' concerns. So you say that you were aware that they were concerned that it could be a chemical injury. How did you become aware of this sort of general concern?
In the late evening, I think it was my registrar who was on at that point, was delivering a message or information that he had heard that the ambulance team had pre-alerted the hospital, that they were in attendance to somebody else, I think either at or close to the address that Dawn had been found. I can't remember if they said it was her partner Charlie or not at the time, but certainly that's what we thought. We had never seen Charlie Rowley up to the point that he was admitted to the intensive care unit. I didn't know why they had their suspicions at that time.
But so if I can just pause you there. So you think you became aware of those suspicions probably from your registrar, who would
Almost
have
as a word of mouth, because they were looking, I think, to try and find out if they needed to try and test him in any way when he arrived.
Okay.
My registrar, I think, mentioned that the ED consultant was going to try and contact one of his colleagues for advice. Paul had been present when the Scripples had arrived in the hospital, and so would have been familiar with that presentation. And he's also our CRBN lead in the hospital. And that was, to some degree, all that we really heard. Okay. I wasn't sure if they were looking for the point-of-care testing kit that we had on our ward, that we used before.
Dr. Jukes, if I can just pause you there, just before we move on
Yep.
to the rest of that. I just want to focus for a moment, if I may, on this concern of the paramedics. So you say you think you became aware following conversations with your registrar. You say you didn't know the reasons behind their concerns. If I can take you to the clinical records, inquiry reference 4173, page 2, please. We could just bring that up. So these are part of Charlie Rowley's records from the hospital. This section has been completed by the ambulance paramedics, and I'm going to ask you about it in a moment, but I'm just going to read it out first. So it says, arrived to find gentleman, Glasgow coma 11, increased tone to upper limbs, making incomprehensible sounds, leaning against the wall, not responding to commands, pinpoint pupils, sweating and salivating profusely. No drug paraphernalia present initially. Drugs use was denied by the occupant. Heart requested, clinical care requested, airway management and ventilation support is noted, naloxone given, intravenous access attempted but failed, and then intraosseous access was achieved. And then they performed the ABCDE assess airway, breathing, circulation, disability exposure assessment that we've heard about. And then treated such as nerve agent incident with atropine as charted. You didn't see this record from the paramedics at the time that Charlie was admitted to the emergency department, is that right?
Oh, when Charlie was admitted to the emergency department, we were not involved.
Would it be possible for you to check with the paramedics, either by accessing this record or phoning them to find out why they had these concerns about Charlie Rowley's
Well,
presentation.
wait a minute. Hadn't we better establish whether he knew that they had?
Pardon me, sir. I'm not.
Well, I want to know when it is that you discovered that the ambulance people had some concerns that this might be a nerve agent incident. This document records it, but you say you didn't see this.
I didn't.
Right.
So I had awareness in the sense that I was almost being relayed a story about the ambulance team are at the scene. They've got someone who's acting very odd. It might be connected to Dawn Sturgess. I guess they were looking for a way at that time to see if we could contact anybody in support of testing, if they had to do any tests. I assume that was to do with acetylcholinesterase levels, while they were also talking to others about it.
If I can just pause you there, Dr. Jukes. In your statement at paragraph 28, you say, we were also aware that the ambulance crew, which delivered Ms. Sturgess's partner to Salisbury District Hospital, had had concerns that a possible chemical injury was causing his symptoms. So in your statement, you say that you knew that they were worried about this.
But I didn't know really why.
You didn't know why, exactly. So what I'm exploring with you is, firstly, this is why
Yeah.
the paramedics had these concerns. They've documented them in the record. You haven't seen the record. Was there any way for you to obtain more information to find out why they had these concerns?
When Charlie Rowley arrived into the ED department, the next message I got back was he's arrived. It doesn't look, there doesn't seem to be all the problems that they initially were concerned about. My colleague had also seen him and felt that this was unlikely to be a nerve agent. And it seemed to have decreased the concern about him to a point where he was not somebody that we needed to rush down to see. He had no organ support needs. And so I didn't, at that time, feel a need to go down to see the ambulance record, because at that time it looked like it was going to be something that the ED department could control.
Okay, so if I've understood correctly, you could have gone down to see the ambulance record, but you didn't feel it was necessary because you'd had this reassurance from a colleague. I'm assuming that's Dr. Russell.
I think again my registrar came back with those messages.
Okay.
We had used, probably using him to make sure to catch up on that story. What had unfolded? Was it something I should be worried about, or had it actually settled down to something that was going to be addressed by the ED department, the emergency department?
I see. We heard from one of the paramedics, Ben Shannon. His evidence at the hearing on the 18th of October was that he was met by Dr. Russell when delivering Charlie to the emergency department, and that he told him his reasons for suspecting nerve agent poisoning, and that he also told Dr. Russell that he had administered atropine at the scene. I take it that Dr. Russell didn't pass on that information to you, either directly or through your registrar. Is that what you're saying?
I didn't get any message from Paul Russell, although I think his role had been to come in to try and support that worry. He wasn't on call at the time. I think he was doing it to try and offer some reassurance to his emergency consultant colleague. But I didn't speak to Paul Russell directly at all.
I know it's difficult always in retrospect, but do you think if you had known the reasons behind the paramedics' concerns, so Charlie's unusual presentation, the increased muscle tone, the profuse sweating, the profuse salivation, do you think this would have changed your view about the likeliness of organophosphate poisoning?
It is hard to give an answer to that, in the sense that there was a lot of other conflicting information that Charlie, although he had denied using drugs, had a strong history of intravenous drug use. We were aware of that. I think the ED department had seen him before. He was behaving in a bizarre manner. That's what they reported as we looked through these things later. And I've seen a lot of people that have come in with opiate and mixed overdoses or recreational drugs, not opiates mixed with cocaine, amphetamine and other agents, and they can behave in the most bizarrest, sweatiest manner. So it wasn't conclusive that, though again you had those symptoms that you could pick out as a confirmational bias aspect in a hindsight. So I think had he said that and had some atropine in its own right, it wouldn't have made me think that we should start immediately looking for organophosphate poisoning. When he later, as I'm sure you're going to mention, as it did eventually come to us, things were obviously affecting that slide of decision of judgments, which way were things going. But at that point, it looked like he had arrived in ED, the concerns that the ambulance team had seemed to have settled. He was, I describe it as not in a completely normal behaviour, but was able to not require any organ support whatsoever at that time, and we were unlikely to need to meet him at that point. So in that own right, in that sense, I wouldn't expect that to have changed the management.
I see. You say that you'd seen a lot of patients presenting with symptoms of, opiate overdose, but it was unusual, perhaps unprecedented, wasn't it, to have the paramedics concerned and in fact treat a patient for a chemical injury such as Novichok poisoning?
It was,
Do you agree?
and I don't think it certainly, again, was absorbed as that is odd. They obviously had such a degree of concern about it. It would be hard to excuse that as being just purely enthusiastic or concerned or seeing things that aren't there. But as I say, by the time we had more direct, well, the hospital had more direct contact with Charlie Rowley, those concerns seem to have settled down.
I see. Well, I'm going to move on from that now, but just to clarify something. So when Charlie Rowley first was admitted or taken to the emergency department, you didn't think at that stage that he would necessarily be admitted to the intensive care unit. Is that right?
I did not think, there was no reason to think that at that moment in time.
Okay. You also said in paragraph 28 of your statement, which we looked at, that the ED consultant at the time contacted Dr. Russell, who had expertise in the area, and his opinion was that it was highly unlikely that a chemical weapon was involved. So I'm going to take you now to Dr. Russell's statement, and that's INQ reference 005990. Paragraph 20 on page 4. So here we have Dr. Russell's statement in his account of meeting Charlie Rowley. He says, "I waited in the department for the male patient to arrive. He was identified to me as Mr. Charlie Rowley. He was unresponsive, with a fixed leftwards gaze, pinpoint pupils, and grunting. His vital signs were within a normal range. He was stripped to his underwear for examination. Apart from being sweaty, the evening was warm. There were no signs of vomiting, incontinence, or muscle fasciculations, twitching, seizures, or increased secretions. I felt that his presentation was in keeping with opiate overdose." I recorded my opinions and suggested that as a precaution, we should use the cholinesterase testing machine that we had in the emergency department. Unfortunately, the machine failed, so I suggested we use the kit in the ICU. This was not done before I went off duty and left for home at approximately 9:30. Months later, I learned that the patient had been given an oxine atropine auto-inject by the paramedics at the scene. Had I known this at the time, I would have been more inquisitive about the presentation of Mr. Rowley rather than accepting the facts I had been given about him at face value. Now, just before I ask you the question, I should make clear here that Ben Channon, the paramedic's evidence was that he did inform staff at the handover that he had given atropine. And in fact, as we saw it a moment ago, it's in the records. But leaving that to one side, were you aware that Dr. Russell's view was that the ICU machine, the testing machine, was to be used to check for cholinesterase inhibition?
I wasn't aware of a request by Paul Russell for that.
Okay.
I have a vague memory of the ED consultant coming up to the ITU to look for our machine. There was two machines, one in ED and one in the ITU.
I can just pause you there because it might be helpful to have a bit of background about those machines. So those are machines, are they not, that you had still at the hospital left over from the Skripal poisoning in March, and they could be used to give you a reading pretty quickly about whether there was acetylcholine esterase inhibition. Is that right?
Yes, they were not the same tests that we would have had from the laboratories either at Birmingham or at DSTL, but they gave a guide that we could use as opposed to having blood going backwards and forwards, which took time to get processed.
Of course.
There were machines we had. I thought both machines had gone back. I'm pretty sure I've been told machines had gone back. So I was surprised, but pleasantly surprised that initially I thought that ED still had their machine. I can't remember when. I actually thought it was after Charlie Rowley was admitted to our ITU that I was told that their machine was broken. I thought I remember that the ED consultant had come looking for ours or to check if we had one, and I would have said that we didn't have one because I didn't believe we had one.
Okay. And so you weren't aware that Dr. Russell's view was that the ICU's machine should be used at that early stage to check for acetylcholine esterase inhibition?
No, but it explains why I thought I had a memory of the ED consultant coming up looking for us.
I see. So you think perhaps it was the ED consultant that was tasked with doing that? Do you
Yes.
think? Okay. Before we move on from Dr. Russell's statement, I'm just going to note that at paragraph 20, he notes that he says both the woman and the man were known for substance abuse issues. As far as you were aware, Dawn was known to the trust for alcohol dependence. We've seen that in the record, haven't we? But she was not known to the trust for any other drugs abuse that you're aware of.
Not that I was aware of with the records I had.
Okay. And just to finish off, so Dr. Russell, he notes that both the man and the woman were known for substance abuse issues. Dawn's previous alcohol issues, they weren't relevant in assessing the cause of her symptoms, were they?
I didn't think so.
Okay. I'm now going to ask you about your communication with FT49 on the 30th of June. If we return to your statement, which is inquiry reference 4411, page 6, paragraph 29. It's a little difficult to read, so I'll read it out. So you're talking here about Dr. Russell had informed you that his view was that it was no chemical weapon was involved.
Dr. Russell hadn't informed me, but the message that I received was that he had been content with that it wasn't a poisoning.
Okay. And then you continue at paragraph 29, you say, despite this reassurance, there was still a degree of concern that there was something more to these admissions. The possibility that they were related to some form of poisoning was hard to shake, despite it being incredibly unlikely. At 1952, I messaged one of the experts at DSTL Portendown, who I knew from the previous poisoning incident in March, inquiring who I might contact at Portendown to do urgent acetylcholine esterase levels. Soon after sending that text, I received informal information from a member of Wiltshire CID that there had been evidence of drugs at their house. I passed the information on as another text. I passed the information on as another text message and suggested that the evidence was far more in keeping with opiate misuse. I did not receive a reply to these messages at the time. If we can move to the text messages, they are inquiry reference 005067. So looking at the very first message, this is 1952, so nearly 8 o'clock at night on the 30th of June. Hi, FT49. I am after a little favor or info. Essentially, who do I need to contact to do some acetylcholine esterase levels at Porton? I think the ED team are going to try and contact too. Before the hospital goes panic-stricken, I was hoping to prove all is well. The story is too long to text, but involves 2 admissions of unconscious bradycardic people. One has arrested. No sweating, poor history of diarrhea, but yes, pupils are small. Probably drugs, but hazard suits have already been mentioned. Cheers, Stephen. Pardon me. At that point, on the 30th of June of 2018, there was a record of Charlie Rowley sweating, both by paramedics, although I appreciate you hadn't seen those records, but also by Dr. Russell. I take it from your message with FT49 that you actually weren't aware that Charlie Rowley did have a history of sweating. Is that right?
At the time I sent that, I wouldn't have known that.
Okay. And I think you told us that Charlie Rowley was actually admitted to the ITU just after midnight. Is that right? So he wasn't actually in the ITU yet at that stage. Okay.
If I may, this message was sent as much to try and provide another route for getting acetylcholinesterase levels for the ED team. This was before Charlie had been reviewed. This wasn't necessarily just because I was thinking I need these results at that moment in time. The difficulty we had at the moment was 2 patients seemed odd, even though this patient at that time hadn't been brought into the hospital. But there was strong, I guess you would call it, situational evidence that this could be all related to opiate or or other recreational drugs, a mixed drug use, it was possible. And so that was why I mentioned probably drugs, and hazard suits obviously meant hazmat suits.
I see. A little later on, you text and you say, so we have found the point of care kit and the ED guy, Laszlo, can use it. Might stop everyone trying to decon everything. Also, CID have just told me they have evidence of drug use at the house. As we thought drugs, sorry to have bothered you, trying to, I think that should be, prevent a wildfire from inappropriately taking off. Cheers.
I think so too.
Okay. He didn't respond to your first text message, but his evidence is that he phoned you that evening. I'm going to take you now to his account of that phone call, if I may. It is recorded in his statement at INQ 5997, page 7, paragraph 24. I recall Dr. Jukes explaining that one known regular hospital attendee, a recreational drug user, and his partner had been admitted to intensive care. One of the casualties had sustained a cardiac arrest at scene, and with advanced life support measures had a return of spontaneous circulation, was now intubated and ventilated, had ongoing pinpoint pupils and bradycardia. He explained a second casualty from the same location had been brought into hospital some hours later, again with pinpoint pupils, and was also bradycardic. Both patients were being treated with supportive therapies, naloxone, with some need of atropine. At this point, my opinion was likely diagnosis was that of a potent opiate or mixture. FT49 says that he told you that the only definitive way to establish if there was an organophosphate in a contaminated batch, let's say, of recreational drugs, was to send blood samples to Birmingham toxicology labs, and if available, to use the point of care kit. Do you recall that that's what he told you?
I can't recall when FT49 contacted me. I thought it was more the following morning, but it could have been that late that evening. Mm-hmm. But I usually record the phone calls I have when I'm on call, and I had one before 7 o'clock the following morning. I can't remember a lot about that phone call, but I do remember him telling me that if you needed blood tests from DSTL, that it would need to go via the police as a request. I can't remember if he told me about sending the bloods to Birmingham. He might have done, because the following day we did do that. We sent some bloods to Birmingham, but after I'd gone through our own biochemistry lab, which makes me think at the time I was probably trying to do it on my own back to contact a lab to see what we did, see what we had to do. Was it Birmingham, or could they do them? I suspect that's what he told me, but I can't remember it.
Okay. Leaving the blood tests to one side and returning to this point of care kit. So you told in your text message at 8 o'clock, you said that we had found the point of care kit and the ED guy can use it. Was it used at that stage, do you recall?
So when I say we, I guess I meant the hospital. What I really meant was I was under the impression that the point of care test in the emergency department had been found, that the ED consultant could use it, and I was unaware that, as I found out later, that it was broken and they was unable to get any result from it.
Okay, because Carrie Law's statement records that you had told her that evening that the machine to test for nerve agent wasn't working due to battery issues. So does that seem right to you?
I don't know. when I found out that the machine wasn't working, and I don't know if I did pass that on. I don't know where else she would have got that information from as easily, so I suspect that it must have come from me, but I don't know when I found out that the machine hadn't been working. It doesn't quite fit in with the timeline, because if I texted FT49 saying we found the machine and I've just spoken to CID, that would have suggested that at the time I was speaking to CID, I was still under the impression that the machine was going to be used.
I see. Well, I'm going to come on to police involvement in a moment, but as I see that it's 3 o'clock now, might this be a good time for a break, sir?
Yes, of course, Ms. Bottle, if that's helpful. 3:15, please. Dr. Jukes, you're in the middle of the evidence, so keep it to yourself.
Thank you.
And come back, please, at 15:15.
Right.
Yes, Ms. Bottle.
Dr. Jukes, before we finished for the break, I mentioned that now I'm going to move on to the police involvement on the evening of the 30th of June. We know that Kerry Laws attended Salisbury District Hospital on that day to speak to you about the admissions of Don Sturgess and Charlie Rowley. Her statement, if we could pull it up please, is inquiry reference 6105. And if we can turn, in fact, just at the bottom of page 5. Yes. Ms. Laws says, we were introduced in the staff room to Dr. Stephen Jukes, who was the duty consultant in charge of Dawn's care. And I should say, just for context, that she arrived at the hospital at 1945. I remember that we had a discussion with Dr. Jukes about Charlie Rowley, who is expected to be admitted to the hospital imminently. We agreed that it was worrying that we had further patients from the same address. We went on to have a long conversation about the circumstances of this incident. I made a short précis of the relevant parts in my notes as follows. On arrival, Dawn had presented as not foaming at the mouth. It was spittle at most. She had small pupils and no sweats. Dr. Jukes also stated that he had been involved in the initial treatment of the Skripals from the Salisbury incident, and his opinion was that if these circumstances had arisen prior to that incident, he would have thought that this was a drugs overdose. Can I take it from that last sentence that because this incident had happened after the Skripal incident, that you weren't convinced that this was just a drugs overdose?
That, I think what I was trying to say there, I can't remember the full details of the conversation, but the police officer has obviously taken some contemporaneous notes. I was trying to explain that before the Skripals, I would have taken this as being a drug overdose, as a within the differential. That although we've been through the Skripals incidents and the nerve poisoning, that at that point in time, it was very hard to marry up how 4 months down the line and 8 to 10 miles away. I did notice on the first document that you showed about the concern about what would happen if nerve poisoning was found accidentally, and it did comment then that it was a local contamination as opposed to 8 or 10 miles away. It was hard to marry those up at that time, and therefore I should consider this in the same light. That, and I know you've heard this beforehand, that common things are common. It's simply because we look to those first because they happen more often, but we don't ignore the possibility of other events. It is a phrase we sometimes use about finding hoof prints on a beach. You should think of horses, not zebras. And we'd already seen what we jokingly called a unicorn in Salisbury, something unbelievable. The chance of it happening again was very remote, but it wasn't something that we would completely ignore. So, but at that time, I was trying to look at this in a very open way and not trying to immediately look into clouds and see faces just because I had been involved with the Skripals.
Okay, but you mentioned the Skripals in your conversation with Dr. Jukes. So can I take it from that it was something that you hadn't completely discounted? It was at the back of your mind?
Oh, yes. It's never forgotten.
Okay. I want to ask you a bit about what you told what you told the police officer. You said no foaming at the mouth. It was spittle at most. But we've heard, haven't we, that you had a conversation with your registrar where she noted that there were secretions.
So I'm not sure I've ever used the word spittle, so I'm not sure how to answer that one. The secretions, as I say, that may have been present on Dawn's initial presentation to the hospital could have easily been explained by secretions because you have a breathing tube in or regurgitation from fluid from the stomach. I guess I was trying to condense all that down into something that I could describe to a non-medical person.
I see. Carrie Laws states that she then told you about recent police intelligence regarding Charlie Rowley's involvement with drugs. And I'm looking here at paragraph 18 of her statement. If we could bring that up again. That's document 6105. She says, during these conversations, I took the decision that I needed to pass the recent drug intelligence relating to Charlie Rowley to Dr. Jukes. I passed him brief information I had read previously and as recorded in my notes. I don't remember precisely where in our conversations that I did this, but I am sure that it was in the early stages. I advised him of the police intelligence regarding Charlie Rowley's involvement with drugs. And I provided this information to Dr. Jukes as my overriding concern at the time was that this information could be critical in saving the lives of both Dawn and Charlie, together with anyone else who could have been involved. Carrie Laws doesn't mention here passing on intelligence relating to Dawn Sturgess, but she does later on in her statement at paragraph 31. If we could just pull that up, please. In this part of Carrie Law's statement, she's not talking about her conversation with you, but she's explaining an email that we saw earlier this morning, sir, that was shown to Aaron Martin.
Yes, I remember it. What's the question for Dr. Jukes?
Yes. So in this statement, Carrie Laws explains that she had commented that the patients were two well-known drug addicts. And Carrie Laws says, I did not know Dawn at that time, and that her assessment of the intelligence, in fact, was that she was a drug addict. But she apologizes for making that assessment and accepts that she's incorrect about that. And what I want to ask you is, when Carrie Laws came to see you at the hospital, bearing in mind that Dawn was your patient, did she mention to you her assessment that Dawn was a drug user at that time?
I can't remember that she said anything about Dawn at the time. I can't remember. I was aware of what she said in regard to finding evidence of drug use at the address, but that was all I can remember from that conversation.
Carrie Laws says that you told her in your conversations, and this is at paragraph 22 of her statement, that Dawn's symptoms were not symptomatic of a pesticide overdose or other poison. The symptoms are fitting with an overdose of opiates. Do you remember telling her that?
I don't remember telling that. I don't mean to say that that's not possible that I did, but I don't remember saying that. I think at the time, as I say, we had a differential, one of which was that some of these problems that we were seeing were as a result of using opiates. And as we were moving through the evening, there was, I guess, an internal swing between, is this more than I'm just thinking, or am I actually looking for something which isn't there? Again, that confirmational bias, looking for things to try and make it fit. I can imagine that I was trying to, at that point in time, saying that we still were thinking more along the lines that this was more drug-related than anything else at that time.
Okay, because what she records in her statement is a more sort of stark statement that you had told her that the symptoms, that Dawn's symptoms were not symptomatic of pesticide overdose or other poison. But as we discussed a moment ago in relation to her medical records, in fact, she was exhibiting a lot of the symptoms of organophosphate poisoning, which is, of course, the same as Novichok poisoning. So she had meiosis, she had secretions, she had diarrhea, she had respiratory and cardiac arrest, she had bradycardia and hypothermia. So this statement, if you had given it to Kerry Laws, would have been inaccurate. Do you agree with that?
Not fully, because the size of symptoms we were seeing, there were, at that time, there was alternative rationale for what was happening, what was causing them. So if you looked at it from that point of view, that these were not a constellation of symptoms and signs consistent with a cholinergic toxidrome. These were symptoms and signs that were consistent with somebody who had suffered a cardiac arrest and had been exposed and had, at that moment, situational evidence that made the probability or the possibility of opioid use reasonable enough to consider it above those signs being something of a organophosphate poisoning.
Yes. So at that stage, based on all the information you had, the signs and symptoms, the sort of primary hypothesis was that it was a drugs overdose. But what I'm asking you is something slightly different, is because they're not mutually exclusive necessarily, are they? And the signs and symptoms that she had at that stage would also be consistent with organophosphate poisoning.
If you took the individual signs and symptoms out on their own, without considering anything else or any other context, then yes.
Okay. And so you say you can't remember whether you told Kerry Laws that her symptoms were not symptomatic of a pesticide overdose.
I can't.
Okay. But that wouldn't be correct, would it?
I don't think I would have. What I would have said, I wouldn't have. It wouldn't have been as black and white as that.
When Kerry Laws attended Salisbury District Hospital on the 30th of June, the police had information available to them, which I'm going to set out for you now. So they knew that the ambulance service had assessed that Charlie was suffering from nerve agent poisoning. They also knew that the ambulance and fire services were responding on the basis that Charlie was suffering from nerve agent poisoning. They knew that Dawn had no previous convictions, cautions, or reprimands for drug use or for any other offenses. And they also knew that they held no intelligence that Dawn was a drug user. If Kerry Laws had shared that information with you, do you think that might have changed your assessment of the likely cause of Dawn's symptoms?
I don't know, is the simplest answer. It's such a lot of things that I didn't have at the time. I don't know if I would have needed all those things. I still had my internal worries that there was something else going on, but there was constant, nothing ever became so clear cut. Everything was not quite enough from what I'd seen beforehand. So, but honestly, I don't know. Clearly, if I had all those things spelled out and then in front of me, all at once, and I was able to see all these things, then perhaps it would do. But it's hard to know without actually being able to have experienced that timeline. So it's hard to say for certain. But these things, new information is always likely to tip the balance.
Yes, and bearing in mind that the primary hypothesis at that stage was a drugs overdose, it would be a reasonable supposition that being told that there was no evidence, no intelligence that she was a drug user, that she didn't have a record, any cautions or convictions for that behavior, do you think that might have tipped your thinking away from that primary hypothesis?
It could have done, but if you've got somebody who has no record whatsoever, it doesn't mean that that doesn't occur. These things are still possible. I've met plenty of people who have had no records, but they present with a drug overdose or use of recreational drugs, but it's got, I guess, out of hand at that time. So in itself, just having no record, I don't think is no guarantee.
No, I see. And I'm going to move on from this in just a moment, but just one last question. Aside from the intelligence regarding drug use, the other facts that I set out for you are to do with the paramedics' concerns. Mm-hmm. I took you a moment ago to the records of the paramedics who treated Charlie, who treated him for nerve agent poisoning with the atropine. And they were so concerned about the risk to themselves that they wore PPE, even at the hospital. Mm-hmm. Your colleague, Dr. Russell, told them they could take it off, and they didn't because they were so worried. Mm-hmm. Do you think if you'd had all that information together with the drugs intelligence information, that might have tipped the balance away from
those elements? I guess I already had a flavour from hearing that they were concerned at the scene, that they were feeding into that growing concern that I had internally. But when presented, you're looking for your own evidence to support it. And although I was getting it, I guess, indirectly from the reports back from ED when Charlie Rowley had first arrived, that their level of angst had settled down, that didn't then support my concerns. So I had to sort of pause that at the moment. So I was aware about those things, and it did feed in, but until you're able to see, I guess, with your own eyes, a change, then I would have held where I was at that time, waiting for new information to come to me that I would be able to see and act upon.
Okay. I'm going to ask you now about the 1st of July and the decision to treat Dawn and Charlie for organophosphate poisoning. Mm-hmm. If we can turn to the records, inquiry reference 00130, page 5. We see the first handwritten entry there is 4:30 in the morning on the 1st of July. And I think, is that your name?
No, that was the night registrar, and that would have been Dr. Stephen Phillips.
I see. There's a record there, 44-year-old female, and there's the word, I think, diaphoretic at the bottom right-hand corner. Do you see that?
Yes.
Does that mean sweating?
Yes.
And we can see that there's a persistent bradycardia, significant volumes of saliva to the oropharynx, I think that is, and a temperature of 35 degrees. In your statement, you say that you returned to the ICU at 7:45 in the morning. If we could turn to page 6 now of this record, just one page over, we can see your first note in the clinical records is at 11:50, so sometime after you arrived. Can I just check, would you have read that review from the night registrar when you arrived in the morning?
So when I arrived in the morning, I would have had a handover from the night registrar. So I wouldn't have gone straight to those notes to read it, because I would have got it from himself at that time.
I see.
During the night, obviously, we had admitted Charlie Rowley, and he handed over his concerns, or at least he described the issues the ongoing issues with Dawn. Charlie, in fact, had got better, I guess, for want of a word. He had improved in his overall function without any form of treatment apart from supportive. He did mention, and I was aware of those concerns at the handover.
Okay. So you knew that she was sweating, her bradycardia hadn't resolved yet. She still had these significant volumes of secretions.
So the bradycardia wasn't a surprise, given that the concern about where in her heart that there may have been an injury. That area is often associated with a low heart rate. It almost takes that one as a very strong reason for it. So that heart rate was actually, I wouldn't go as far as saying acceptable, but it wasn't causing a concern. And I was aware about the secretions and the sweating from him.
Okay. And then if we turn to the next page, page 7, this is all part of your record at 1150. And you say concerns, and it says likely drug overdose, but concern if this was, and then I can't make out that last word, but I can see, I think, organophosphate underneath it. Is that right?
Likely drug overdose, but concerns if this was contaminated by long-acting opiate, organophosphate, or something else.
Okay. In your statement, if we can turn to that, reference 4411, page 8, at paragraph 37, I think you set out your reasoning for starting to consider organophosphate poisoning. You say the partner of Miss Sturgess had been admitted to the ICU in the early hours. When I reviewed him, he had the characteristic appearance of a patient who had been paralyzed for an operation but had not had his paralysis fully reversed at the end of the procedure. The patient can feel like they're struggling for breath, and it is associated with problems of the acetylcholine system. This reinforced the doubts that I had about what had precipitated Miss Sturgess's collapse and cardiac arrest. When taken together with her clinical signs that had not settled as expected, such as diarrhea, small pupils, and evidence of sweating despite not having a temperature. These are signs of cholinergic overactivity, and I was convinced that this had to be considered as a possible diagnosis. So the clinical signs that you would have expected to have settled, would those be the diarrhea and the small pupils and the sweating, is that right?
The small pupils, there had been, as part of the sedation that was given to Dawn when she first came in, it was a mixture of one agent called propofol, another one called fentanyl, which is a form of opiate. That had been stopped in the early mornings because it could have contributed to the ongoing small pupils. I would have expected that its effects should have settled by the morning, by the time that I went to review her. Mm-hmm. The sweating, that was harder to explain, that it had been continuously ongoing. The diarrhea still could have been related to gut ischemia, as in a low blood pressure and oxygen levels to the gut. It looked like, at that time when I reviewed Dawn, the balance was swinging against it just being something as simple as an overdose. However, I also did a test to try for her assess her muscle function, where you literally pass a small current to her forearms to see if they can twitch in coordination with the current that you send. With the Skripals, we had done that, and at times there was no twitches, whereas with her we had full twitches, which would go against it. At the same time, Charlie Rowley had improved so much, effectively with no treatment for organophosphate poisoning, that we were able to take out the breathing tube. And yet, a little later on, as a few hours later, he seemed to have been working a bit harder for his breathing. So I went to see him, and I thought, that looks to me like somebody who, in the distant past, we used to see who hadn't had enough medicine which we use to counteract the effect of the paralysis we deliberately give for some surgical operations. At that moment, I couldn't see everything that was pushing towards this is something else. All my worries, the concerns, where I thought, am I trying to find some form of organophosphate poisoning? Am I looking for that background concern? I couldn't ignore it now at all. And so at that point, I'd already made the decision that we were going ahead to treat them, while I also tried to confirm that diagnosis.
Treat them for?
Acetylcholine esterase inhibition.
Thank you.
That didn't mean that I was certain of its
I
background.
just wanted to know what you meant.
Sorry, sir.
Also, in the records, it shows that at 15:20 on that day, that you record in the notes that you'd obtained the point of care kit.
So
Do you recall that?
the timings were in many ways after the event. I'd done all the things and then I was recording them down.
I see.
So in the morning, I came across the point of care test that was on the ITU that I thought had left. And I found the manual and I thought I can use this because it will give me some more evidence while we're sending bloods off to laboratories. We'd already, as I say, considered that earlier on in that day, sending off bloods to Birmingham, because I knew they would take some time to come back. It would at least give me more working evidence that our treatment was correct.
So if we can just focus on the point of care kit just for a moment.
Yes.
That is, again, the machine that will give you a kind of more or less immediate reading to know whether there's acetylcholine esterase inhibition. Carrie Laws records in her statement that you told her the previous evening that it wasn't working because the batteries weren't charged. Is your evidence that that's not correct, that you simply couldn't find it until the next day?
That one would have referred to the one that was in the emergency department.
I see.
I didn't come across, I knew nothing about the one that on the intensive care until I found it on the day that I did the test.
I see. You thought that it was gone, but it was actually still there.
Yes.
You came across it and you
Yes.
decided to use it.
Literally.
Okay. You felt that it was necessary to get confirmation of the results from the point of care kit by sending blood and urine samples to the toxicology lab in Birmingham. That's right, isn't it?
Yes, that is right.
But you were prepared to start treatment therapy in the interim before you got the results back.
Yes.
Is that right?
We effectively started treatment, I think it was about 24 hours before we had the confirmation test, whereas with the Scripples, they started it 4 hours after they got the confirmation test.
So I can take you through it quite quickly from the records. You inserted the central line at 4 o'clock in the afternoon. In fact, we have that from paragraph 43 of your statement. And it was necessary to insert a central line to give the medication, is that right?
She was going to need several infusions of different medicines. She was going to need more sustained access to her blood vessels, and a central line would allow me to do that.
Yes. So the central line is a long, thin tube which goes into one of the larger veins, which can be found in the groin, the neck, or just under the shoulder, and it allows the administration of irritant medications or multiple medications at once. And this was necessary to allow the pralidoxime and the atropine and the midazolam and the glycopyrronium to be administered, along with the hyoscine. Is that right?
Some of those medicines, for example, the glycopyrronium and the hyoscine, could have been administered as single injections into a peripheral cannula, but those other ones you mentioned were infusions. At the same time, she would have been getting some propofol as well. And so there were effectively a lot of medications going into her, and it was just trying to establish a route that would last for many days.
Okay. And the infusions, you had to have an x-ray to make sure the line was in the right place, and the infusions began just after 6 p.m., is that right?
Yes, the prescription I wrote earlier than that, but there would have been some time, I think, to get hold of the medicines to give her the pyridoxine, and that's why it was started at 6 o'clock.
Okay. I'm going to move on now from your care of Dawn and move briefly to the source of the poisoning, if I can put it that way. At around 6:30 on the 1st of July, so that's around the time that just after the treatment had started, you phoned the police, and a record of that call appears in Kerry Law's statement at paragraph 28. There's no need to pull it up, but for your notes, sir, that's inquiry reference 6105, page 9. The police record of that call is that you said the patient's symptoms are not entirely consistent with a simple opioid overdose, and that you suspect organophosphate pesticide poisoning. While organophosphate is no longer used as a pesticide, you'd noted that it is possible that it was mixed with drugs taken by the patients. The treatment is similar to that for nerve agent poisoning. And you told the police that the female is not improving and the male has deteriorated and that he's on a ventilator. Do you recall calling the police with that information?
I don't recall calling the police, but I would have expected to either have called the police to update them or to get one of my team to have done it, but I can't remember that phone call myself.
Okay. Around the same time, you sent a further text message to FT49, and if we can bring that up, that's inquiry reference 5067, and it's the text message sent at 1839. It begins on page 1. So you text FT49, you say, only to keep you in the loop, we have history, you know, found the point of care kit on the unit, read the instructions and hoping for user error as the results are consistent with cholinesterase inhibition. A formal sample has gone off to Birmingham because you, Port and Lot, are no longer interested in the civilian stuff. So running diagnosis, contaminated drugs with pesticide, pralidoxime, here we go, unless they were randomly selected by the Russians to test us again. Here, you're considering two distinct possibilities. Either I think that the drugs are contaminated with organophosphates, or some sort of Russian targeting, as you say, unless they were randomly selected by the Russians. Can I just ask the question? I took you at the very beginning of your evidence to this reasonable worst case scenario document about a discarded container. Do you think if that sort of planning had been shared with you by the authorities, that you might have considered that third possibility?
I did consider the possibility that this could be an accidental acquisition of a nerve poisoning agent, that somebody could have accidentally picked it up. I couldn't quite work out still how it ended up from, assuming it had been discarded in Salisbury, to Amesbury 4 months down the line. It seemed hard to work out how that would have happened, but it had to be possible. Not, I know I put randomly selected by Russians to test it again. That was a slight attempt at a little bit of, not humour, but just as a nod that I was thinking about Novichok, not just in case the Russians had randomly selected somebody, but I was also acknowledging that it was possible that it wasn't just that somebody had found it and it managed to get its way to Amesbury, but it was also possible that it was also another attempt at an attack, which was quite worrying, but I was not ignoring the possibility that this could have been accidental finding of the Novichok.
All right, I'm going to ask you now very briefly about the 2nd of July. You handed over to Dr. Donison on that day, and you carried out together a joint review of Dawn Sturgess, is that right?
Yes.
At 1845 that day, Dr. Donison made a note of his discussions with the Birmingham director of the National Poisons Information Service, because he'd received the results of the blood tests that you had sent, and that they showed a very marked restriction of acetylcholine esterase. And sir, for your record, that appears in the records at inquiry reference 131, page 8.
Thank you.
There's no need to bring it up. But at that stage, it was clear that this was a nerve agent poisoning. Would you agree with that?
I felt so, because what we were looking for was evidence of cholinesterase inhibition, and there was, and from the toxicology that that there was no evidence of pesticide present that they can test for. Mm-hmm. It still means it could be present, but at that point it definitely needed to be excluded. There definitely needed to be some more actual testing for Novichok.
Mm-hmm. But to put it this way, by that stage, once you had the results from Birmingham, the hypothesis shifted, didn't it, from likely organophosphate drugs cut with organophosphate pesticides to something different?
I think, to be fair, as Dr. Donaldson, when he spoke to the family in the next few days, he was still trying to explain that they didn't have absolute proof yet, because they hadn't had the results back from DSTL that Novichok was confirmed. But I think we had assumed that unless something else comes up, something else is proven, or that test was negative, that was our running hypothesis.
Okay. And you were involved in the care of the Skripals, as you told us at the very beginning. The difference between the response to the Skripal poisoning and that of Don Sturgess is partly that when the Skripals were poisoned, the police attended the hospital at an early stage, and they took samples for testing, and those were tested at DSTL. That did not happen with Don Sturgess and Charlie Rowley. That's right, isn't it?
Yes.
You had to send the samples to Birmingham,
yes,
for them to be tested. And then later on, of course, there was testing done at Portendown.
Yes.
Okay. I know at the time, I think at this stage, what I'll do is ask if we can adduce your statement into evidence. We should have done that at the beginning, sir. The statement is 004411, with that correction that you made to paragraph 28. That statement is true to the best of your knowledge and belief. Is that right?
Yes, it is.
It is, okay. Well, so may that be adduced into evidence?
Yes, it may. Does that mean you've otherwise finished?
Yes.
Does it? Right. Just to put it very shortly, Doctor, were you involved in the subsequent days with the assessment of Miss Sturgess's continuing condition, or not?
I was not directly involved.
Right.
I was aware, but not directly involved.
All right, thank you. Now then, yes.
Thank you. Good afternoon. My name is Jesse Nichols. I ask questions on behalf of the family.
Yes.
I have a small number, and I'll try and take them as quickly as I can, conscious both of the time and that Ms. Pottle has covered a significant degree of the groundwork.
Significant degree, yes.
Yes, thank you. Dr. Dukes, my name is Jesse Nichols, and as you just heard, I'm asking questions on behalf of Dawn's family. I'd like to start with some questions briefly about the period between the Skripal poisoning and Dawn's poisoning. Do you understand?
Yes.
Thank you. Now, we've heard in previous days from a number of witnesses that, among other matters, a number of local overdoses of drugs and also a concern about fentanyl overdoses had informed clinical assessments about patients who were coming into the emergency department and to ambulances. Do you understand?
Yes.
This might seem a very obvious point, but does that tell us that local risks to public health inform clinical assessments in certain circumstances?
Yes.
Now, you explained to Ms. Pottle earlier that you had a concern in the back of your mind about the possibility of what was referred to as a risk of discarded Novichok.
Yes.
But, and I'm summarising, that concern in the back of your mind had faded over time for the reasons you've described. Is that correct?
I don't think it had faded. It was still present, but one had to acknowledge that time had passed, work had been done to try and make Salisbury safe, and so nothing had come up in that time.
And can I ask you to look, please, at the paragraph in your witness statement where you touch on that? It's 4411, page 4, and it's in paragraph 16. It should come up on screen.
Okay.
You've seen it already. It's the passage, and I'm going to do this quickly while it's being brought up on screen, Dr. Jukes, because of the time, that starts as far as we knew. So it says, as far as we knew, there had been an extremely thorough clean-up, the point you just made. We had no reason to consider Novichok poisoning. Do you see that? And then you go on. I'm not going to go on with the rest of the text. You've been taken to it already.
So we had no reason to consider Novichok as the primary, or in the sort of top 5 diagnosis when Dawn first presented, because we had possible other considerations at that time. And that's why we didn't consider it when she first arrived into the ED department.
Can we then move forward, please, thank you, to paragraph 29 on page 6. So you say there, first you said no reason to consider it. You've now explained no reason to consider it as primary diagnosis. If we look at paragraph 29, you've seen this already as well. It's the third line. You say the possibility they were related to some form of poisoning was hard to shake despite it being incredibly unlikely. Do you see that?
I do.
So what I understand you to be saying in those two passages is that based on what you knew at the time, the possibility that these admissions were poisonings was incredibly unlikely. That's what you said in your statement in October 2022.
Yes, he's actually only talking about Dawn Sturgess at that point, but understood.
I think it's actually both.
No,
because it's something more to these admissions, plural. The possibility that they were related was incredibly unlikely. So it appears to be referring to
I beg
both
your pardon.
admissions.
I think that's right.
Yes, thank you.
well, certainly at the time, at that moment in time, I don't think Charlie Raleigh had been admitted to hospital, and he certainly hadn't been admitted to the intensive care unit. But during, well, that's trying to...
Just pausing you there, Dr. Jukes, he had, because if you look at paragraph 28 above, you've just described the passage in which he is admitted, and you're then considering the issue in relation to both admissions.
But it wasn't known to, no, it wasn't, hadn't been reviewed by us, and he hadn't required to come to intensive care at that time.
Yes.
Different department, I think, is the point, Mr. Nichols.
Thank you, sir.
But what I would like to sort of try and expand on that is that during the day, there were elements that were just nagging, shall I say, and we've covered already that there was concerns by the paramedics at the time, and although they had been perhaps downgraded by the time Charlie Raleigh had come to the intensive care, into the emergency department, there were these niggles. Now, the problem is, as with all differential diagnosis, you always have to be open to new information, and then you're seeking for something that will either confirm them or something that will make it more likely, further investigations perhaps. But as I say, with Dawn, many times we went to review, there was an awful lot of things that could explain her conditions from other causes. And as we went into the next day, there were, again, further reviews for this. So it was unlikely, but it was still in my mind.
Now, you've been taken through with Ms. Pottle the reasonable worst-case scenario document, and there are others, but we won't go to them, which indicate that the authorities, including central government, were recognising a risk of discarded Novichok in the period that I'm talking about, between the Skripal poisoning and the 30th of June. Now, if you'd been aware of that, do you consider that that niggle would have been harder to shake, and instead of saying we had no reason to suspect and it was incredibly unlikely, there might have been more reason to suspect and more reason to think, well, this could be what's happening?
Given the initial presentation, no, I don't.
How do you explain that? If you explain that the authorities would have given you information that there was an authorised, a state-indicated concern about discarded Novichok, why would that not have affected your niggle?
Because we already had that concern within us. We knew that Novichok hadn't been found, so therefore it had to be possible that it might still be around at some point within Salisbury. I think it would have been hard to challenge the amount of work that was done to try and clean up the area, but nothing's impossible. And so that concern that it was still, it could still be found, was possible. We hadn't forgotten it. So seeing that in writing didn't change that fact. We hadn't forgotten it.
And the fact that it would have come from the authorities and central government saying, we are concerned this is a risk, you're saying would have made no difference?
I'm saying that would have added into what we were already thinking.
I see. Can I move on, please, to any discussion and learning processes that took place after the Skripal poisoning before the 30th of June? Now, Ms Pottle took you to a passage in the reasonable work case scenario document that refers to, and you may remember this, what knowledge training do hospital staff have? Do you remember that?
Yes.
Do you agree that one important way for hospital staff to have that knowledge and training is for the hospital to put it in place after the Skripal attack? I'm not suggesting whether they did or didn't, but do you agree that's one way for that to be relayed to hospital staff?
I think that makes the assumption that there was no training or knowledge already known.
Now, I'm going to come on to that. It doesn't make an assumption one way or the other. I'm just asking whether you agree that that would be a way of relaying that information. Yes, thank you. We've heard from witnesses, including Dr Haslam and Dr Cockcroft, about 3 forms of learning, if I can call it that, following the Skripal attack. I'm going to summarise them because of time. One was a clinical discussion at Porton Down on the 19th of April that resulted in a report on the 9th of July, the day after Dawn died. I don't understand that you were present at that discussion, is that correct?
I'm sorry, I missed that question.
I don't understand that you were present at that clinical discussion at PHE Porton Down on the 19th of April.
I was not present.
You were not present, thank you.
But I've seen the document, and it was attended by one of my colleagues in effectively as a representative of the entire ITU consultant body, and any learning from that would have been passed back.
Yes, the document is dated the 9th of July, so it follows, doesn't it, that it can't have reached you as a document before the 9th of July.
The comments that were made at the time would have come back to us.
I see. The second discussion we've heard about was in the lecture theatre in Salisbury District Hospital on the 21st of June. Were you present for that?
I believe I was.
I believe you were. And the third form of discussion that we heard about was informal discussion amongst hospital staff, which I assume you'd agree did take place after the Skripal poisoning.
Did take place.
Now, for a range of reasons, there is no evidence that we have that in those forms of discussion, hospital staff were warned there is a risk of discarded Novichok. Please keep that in mind when you see future admissions. Is your evidence that that was raised in any of those forums?
I don't know.
Do you think if it was, you would have recalled it and recorded it in your statement?
I don't know.
I'd like to move forward, please, to Dawn's admission. And I apologise for the speed at which I'm moving. I'm sure you'll understand.
Of course.
Thank you. You were asked by Ms Pottle about a single sentence in the statement from Dr Russell. For our notes, it's reference 5990, but I'll just read it out if I can because of the time. It's already been brought up. It reads, both the man and the woman were known to the Trust for substance misuse. And Dr Dukes, you confirmed to Ms Pottle that Dawn Sturgess was not known to you for substance misuse. And you're nodding your head, just for the transcript.
It wasn't known to me,
Thank you.
as far as I could tell, although I will add that when blood tests were taken, she had cocaine in her system, so it is possible that she actually had some form of recreational use, but there was no heroin in her blood at the time.
Yes, and the cocaine was a trace amount that was historic, not affecting diagnosis, yes?
Not at all.
Thank you. I just want to take you to 3 matters that may support the indication you've given that you were not aware of Dawn Sturgess being known to the Trust for substance misuse. One is that you do not refer to that knowledge in your statement at any point, do you? The one that you gave in October 2022. There's no suggestion in your statement that you were aware of that.
Well, he is saying he wasn't, you know.
Yes. The point is simply how strong that position is in light of the other evidence there is, sir.
All right.
I think I would just like to add that with all patients, no matter where they come from, depending on how they present, you might consider that they've had some kind of drug accidental or deliberate. And so the fact that we weren't aware that she had, I guess, officially any form of record that was known to the hospital doesn't mean that it wasn't possible.
Yes. Although that possibility would have been speculative in the absence of any evidence, yes?
It's a clinical diagnosis. You're looking at what you see in front of you. There isn't someone looks like a person who takes opiates or someone looks like a person who takes cocaine. But you do look for some of the symptoms and evidence that might help support that weight. And that would, in some degree, come with the fact that she was found at an area which had evidence of drug use, and her partner was someone who did use recreational drugs. That doesn't mean that at any point you were thinking that means she has to. It simply means that you were considering it as a strong possibility.
I understand, and I'm only focused at this stage on the suggestion that she was previously known to the Trust for Substance Misuse and the evidence that that's not the case. There's just one other point I'd like to ask you about. Can I ask to bring up 5997, page 7, please? And this is the statement from FT 49. He describes in this statement while it's being brought up, thank you very much, it's page 7, paragraph 24, Dr. Jukes, please. And it's the third sentence that starts, I recall, thank you very much. Do you see it says, I recall Dr. Jukes explaining that one known regular hospital attendee, a recreational drug user, and his partner had been admitted to intensive care. So, do you agree he's describing there that you referred to one known drug user and the partner, not two known drug users? Yes?
My text messages to him said that I thought this was a drug misuse. I don't remember saying that we knew that he had one regular drug use.
Well, that would fit with your earlier evidence about knowing of Charlie Rowley, wouldn't it?
Yes.
Yes. Now, I'd like to move on to the issue of what was known about the paramedics' concern, please, and at speed. Now, paragraph 28 of your statement, you say, we were also aware that the ambulance crew had concerns. Do you remember that statement?
Yes.
Is the we in that sentence the treating clinicians?
Yes, the hospital. The people who had been alerted by the ambulance team that they were at a scene and waiting to come to the hospital.
And so you had a situation where you were aware that qualified medical professionals who had seen, assessed and treated Charlie Rowley at the scene were concerned that this was a nerve agent. Yes?
That was their impression at the time.
And so, do you agree that their reasons for diagnosing that would be at least relevant to your clinical assessment?
And it was.
Now, you said to Ms. Pottle that in relation to this issue, I think I'm quoting, by the time that you had direct contact with Charlie Rowley, the ambulance crews concerned had, quote, settled down. Do you remember saying that?
I had no direct contact with Charlie Rowley until the following morning when he was admitted into hospital.
The you, I think there was a we, by the time we had direct contact.
That refers to the ED team.
Yes. Now, by the time the hospital had had that direct contact with Charlie Rowley, you didn't know, and I mean you personally, Dr. Jukes, did you, why the ambulance crew had that concern? You still didn't know, did you?
I can't remember knowing exactly. They obviously had enough concerns, and you would imagine it would be related to the signs and symptoms associated with drug poisoning. But somebody who has got use of recreational drugs, they can present in the most very bizarrest ways. So I don't think I could honestly say with what I knew at the time that this was anything more than this could just be something, an unusual presentation of somebody, and you will need to see them more directly to make an assessment yourself.
Isn't that the very reason that you needed to find out the reason for their concern? Because you were taking into account what the police were telling you about the possibility of it being drug-related, but you weren't finding out from the paramedics the reason that they considered it might be a chemical injury.
Simply because at that point in time, Charlie Rowley did not need any intensive care support. So a patient who comes into hospital, unless they need intensive care support, we're not going to meet them directly. They would go to other wards, depending on what brought them into the hospital in the first place. I didn't meet many of the patients who came during the Scripples incidents who were thought to have relatively minor contact and minor symptoms because they did not need intensive care support.
Thank you. Can I move on, please, to the information from the police?
Thank you.
Now, stepping back from what happened on this occasion, am I right in thinking that if you are told something by a police officer from CID, you are going to take that information seriously and to expect it to be accurate?
Yes.
You've heard evidence that the information that you were told about Dawn did not indicate that the police had no intelligence that Dawn was a drug user and that they had actually checked the PNC computer while they were in the hospital at the time they were talking to you, and the PNC showed no cautions, convictions or reprimands for drug use. You were not made aware of that, were you?
No, but when Dawn first came into hospital and when we admitted her, we were taking her along the lines of effectively a collapsed query cause. We were considering a multitude of options, and we were looking to the ones which are potentially, on balance of probability at that time, the most likely.
Do you consider that, had that information been shared with you, it might have suggested that Dawn's symptoms were not caused by drug use, as compared with the information they had shared with you?
If that information had been shared with me in regard to what you said regarding the computer, it in itself wouldn't have changed anything, because I was trying to treat with her as I found her, from the evidence that I had.
Now, the evidence that you had included the information from the police about the address, but what I'm asking you is, if you'd also had the information that there was nothing on their systems indicating she was a drug user, surely that would also have influenced your assessment.
We were looking at the information we had, and knowing that if the information had said Dawn is not a drug user, all we would have acknowledged was that there is no record in the computer that she takes recreational drugs. It wouldn't have changed where we were at that time.
Penultimate point, please. Can I move on to an entry in the hospital records for Charlie Rowley? And can I bring up, please, INQ 004173, page 3. I think we may have seen it already, but I'd just like to have it on screen, please. Now, before this comes up, Dr. Dukes, you've said in your statement, it's paragraph 28, that Dr. Russell's opinion was something that you took into account in relation to the possibility of chemical poisoning. And you're nodding your head. Yes? Thank you. So you took into account Dr. Russell's opinion on that point in the evening of the 30th of June. And I think this is an entry written by Dr. Russell. Can you see it on the screen?
Yes.
So if you look at the entry halfway down the page, do you see it's dated the 30th of June and it's timed at 21:15. That appears to be when it's written. We could ask Dr. Russell if he was coming to give evidence. Mm-hmm. And there's then an entry that refers to a call at 7:45. So it appears to be an entry later in the evening about an earlier call. Do you see?
Yes.
And it says Russell, doesn't it? Just under the words clinical notes.
Yes.
Do you see that? Yeah. Do you look to the bottom and the final two bullet points, or dash points, if you can put it that way? I read that as saying both known intravenous drug users, no other, in inverted commas, sinister history, new bullet point, information from police suggestive of heroin use. Do you agree with that reading?
Yes.
does that entry, from what you've just seen, if you can't comment, you'll say, suggest that Dr. Russell's opinion was also informed by information from the police suggesting that Dawn and Charlie were both intravenous drug users and the admission was the result of heroin use?
I don't know.
Final topic, please. We know about your texts to FT49 at 7:52 and 8:05 on the 30th of June. And I think you've seen FT49's description of the call he had with you that he puts later that night. Yes? Now, in the text, you referred FT49 to the police information about drug use at the property. And you're nodding your head. Mm-hmm. When you sent those messages and spoke to FT49, if you did so that night or the next morning, you also knew that the ambulance crew who had brought Charlie in had the concerns about a possible chemical injury. Why did you not share the ambulance crew's concerns when you thought it wise to share the police's information about drug use? Because you were telling him, I'm concerned about possible chemical injury here because that's why I want to know about the point of care machine and whether we need to do tests at Porton Down. But you didn't tell him, and by the way, the ambulance crew have said they're concerned that this might be Novichok.
So the initial texts weren't necessarily that I was concerned, that I had that serious concern. The initial texts were trying to find a way, originally to see if they could support the A&D's concerns before Charlie Rowley arrived, whether there was another way to obtain enzyme levels. And later, because it wasn't much later, I was under the impression that they had found the machine in ED, presuming that they had also perhaps been able to test, and then found later that that wasn't the case. And I was trying to relay that we had some more information which at least continued to I guess, support that opiate access was still very possible. And that's all that meant at that time.
Dr. Jukes, I had 20 minutes. I think I've been about 21, so I'm going to stop there. Thank you very much for your time.
Thank you for your help, Mr. Nichols.
Thank you, sir.
Yes, those are all the questions that anybody has, I take it? Yes. Thank you. Have you anything else, Ms. Pottle?
No, nothing more for me.
Then, Dr. Jukes, thank you very much indeed for your help, sir. There's no need to stay or come back unless you want to, but of course you're free to be here to listen if you wish.
Thank you.
10 o'clock tomorrow morning. What's the regime tomorrow morning? Slightly more relaxed, I think. Is that right?
No, it is level 2 tomorrow.
It is level 2 tomorrow morning. Right, so same as now. No devices tomorrow morning, please. Oh, yes, that's right. Yep. 10 o'clock, please.
All right.